بسم الله الرحمن الرحيم. كل عام وانتم بخير جميعا. Today, inshallah, I will talk about important topic in ICU. It's about hypertensive emergency. So initially, I will talk about the definition, types of hypertension, the pathophysiology, clinical picture, target levels, and the treatment. So hypertension is the most common modifiable risk factor for cardiovascular disease, and now is more in younger age, and despite being common, it is inadequately treated. So a quick look about the hypertensive urgency, which is defined as high blood pressure of more than 180 over 115 without organ damage, usually associated with the chronic stable complications like stable angina, previous MIs, previous TIA. It doesn't require ICU admission, can be treated orally. We aim to reduce the blood pressure within 2 days. Quick look about something called pseudo-hypertension, which is atherosclerosis that causes stiffening in the vascular wall, which can prevent vessel compression by external compression of the cuff itself. So it will result in artificial and extreme increase in blood pressure. Clue about it: elevated blood pressure without evidence of organ damage. It seems to be urgency. But we have Osler's maneuver, which is palpable radial artery despite the proximal compression of the sphygmomanometer. So we come here to the main topic, which is the hypertensive emergency, and it's blood pressure of more than 180 over 120 with organ damage. So both the level and the time course will determine the development of the emergency. Lower readings can be seen in children. It can be seen in gravid females and previously normotensive individuals. So this number is not atypical. So it's not defined by specific blood pressure reading. Required immediate lowering, required ICU care and IV medication. Quick look about the pathophysiology. So it will cause endothelial damage, loss of autoregulation, and will lead to end organ ischemia, which lead to vasoconstriction, increase in systemic vascular resistance, and increase in blood pressure eventually. So we know that the hypertensive emergency targeted the vital organs. So we will go through all these things, inshallah, through the lecture. Regarding the incidence, it's usually single organ damage in 83% of patients, but may be present with more than one organ. Usually with cerebral infarction, acute pulmonary edema, and hypertensive encephalopathy. These are the most common things. So first of all, we will do history, full history, including the medication and compliance to this medication. And we will look for evidence of organ damage. If we are thinking about CVS system, we can look for left ventricular hypertrophy signs or heart failure. If we are thinking about aortic dissection, we can look for peripheral pulse examination for absence or delay, alternation in mental status, which suggests stroke, even ischemic or hemorrhagic, or hypertensive encephalopathy. Also, funduscopic examination is very important. We can see papilledema, which is a swelling of the optic nerve. We can see hard exudate and cotton wool spot hairs, which in the result of nerve ischemia. So clinical presentation of the patient usually depend on the cause. They may present with headache, visual disturbance, neurological manifestation like focal deficit, seizure, confusion, chest pain, renal symptoms like hematuria or oliguria, back pain in case of aortic dissection, GI manifestation in case of high ICP. In the right side of the slide, we can see what are the signs of end organ dysfunction and the signs not for end organ dysfunction. We can see that epistaxis and headache alone, they are not a manifestation of end organ damage. So initial labs, we should order what depend on the patient presentation regarding the electrolytes, coagulation profile, chest X-ray, ECG, cardiac enzymes, pregnancy tests, urine analysis, CT or MRI when applicable. So what is the goal of the treatment of hypertensive emergency? It is a reduction of a blood pressure 20 to 25% in the first hour. So in other way, we can say that in the first hour, we need the blood pressure less than 180, and in the next 23 hours, we can decrease it less than 160. So this is the main goal of the treatment of hypertensive emergency in general. This is the guideline that say the same thing that what I mentioned. So this is a long list of the types of hypertensive emergency, but mainly it's a malignant or benign. Malignant, we have only one, which is neuroretinopathy. We will discuss all these together later. Benign hypertension include the cardiovascular system like MI, angina, aortic dissection, central nervous system involvement like encephalopathy, hemorrhage, stroke, preeclampsia. So all these are types of hypertensive emergency. So in most settings, we are avoiding excessive fall in blood pressure because of the potential vital organ ischemia. So assuming continued stability for the patient, we may decrease the blood pressure up to 140/90 for the next 2 days. So we are starting with a neurological emergency, and the first one is malignant hypertension, and also called neuroretinopathy. It is rapidly fatal and caused by change in vasculature, by fibrinoid necrosis, and proliferative endarteritis. Mortality is more than 90% within 1 year, and usually because of renal failure and congestive heart failure. Risk factor, age between 30 and 50, male, African American, and smoker. So those patients, so the aggressive treatment can arrest and reverse renal damage in those patients. And initial lowering of a blood pressure may worsen the renal function initially, but the renal function will improve within weeks. Dialysis may be required for those patients. The second one is hypertensive encephalopathy. It mainly depends about the autoregulation, which is defined by the ability of the brain to maintain a constant cerebral blood flow as the cerebral perfusion pressure varies between 60 to 150, and readings increase if the patient is a chronic hypertensive. So if the cerebral perfusion pressure exceeded the ability of the CNS to auto-regulate, impairment will happen if the MAP more than 150. So the target MAP should be reduced 15% within 2 to 3 hours, not within 1 hour. So in hypertensive encephalopathy, the MAP should be cautiously reduced 15% into 2 to 3 hours because of the autoregulation. There is something called posterior leukoencephalopathy. It's a manifestation, what we just said, of hypertensive encephalopathy, which is inability to autoregulate. They call it posterior leukoencephalopathy. It is reversible vasogenic subcortical edema without infarction. And MRI images showed white matter edema in the posterior cerebral hemispheres. So it may cause coma and death if not treated. It's mostly diagnosis of exclusion. The hallmark is mental improvement within 12 to 24 hours. So if the patient improved within 12 to 24 hours, this raised the suspicion that the patient had hypertensive encephalopathy. Neurological complication happen if the MAP decreased less than 40. We agreed the MAP should be decreased less than to 15% only. If decreased less than 40, the more complication will happen. So there is diagnostic considerations to exclude other causes of altered mental status. So in hypertensive encephalopathy, usually the symptoms developed within 12 to 24 hours. It takes a long time. And acutely in stroke. There will be no focal neurological deficit in encephalopathy. And in comparison with an acute CNS bleeding, encephalopathy improved within 1 to 2 days of treatment. So there will be improvement after 1 to 2 days, and the symptoms developed over 12 to 1 day. So it takes a long time to develop. Also, papilledema is a manifestation of hypertensive encephalopathy. If absent, it should raise the suspicion of another etiology. Now we move to acute ischemic stroke. So when the cerebral perfusion pressure decreases below the level of the autoregulation, we said that in hypertensive encephalopathy, the cerebral perfusion pressure exceed the autoregulation. In ischemic stroke, it decreases below the level of the autoregulation. So the blood pressure will not be lowered unless two situations. If the patient candidate for reperfusion therapy and the blood pressure more than 185, we should treat. If the patient not candidate for reperfusion therapy and the blood pressure more than 220, we should treat. So acute blood pressure reduction is of no benefit, depend on CATS trial, or even harmful in a CATS trial. So that's why the blood pressure should be not lowered unless these two situations. Intracerebral hemorrhage, we have target of systolic blood pressure of 140 to 160 in the first hour based on weak evidence, which is Interact 2 trials that support this recommendation, and no significant reduction in death. There is retrospective analysis of ICH with hypertension that showed systolic blood pressure of more than 160 will be associated with hematomal enlargement. Also, 75% of patients with intracerebral hemorrhage, they have a pre-existing hypertension. So there is no large RCT available to guide the therapy. Blood pressure may remain elevated for 7 to 10 days even after initiation of the therapy. Risk of the therapy, worsening of the bradycardia, which is associated with Cushing response. Sub-arachnoid hemorrhage, we have a target of reduction of blood pressure 20 to 25% in 6 to 12 hours. So in other words, not less than 160 to 180 over 100. Why is that? To prevent rebleeding. Also, we know that in subarachnoid hemorrhage, vasospasm may happen within 4 to 12 days, which is increase the risk of cerebral ischemia. Head trauma, so will increase the ICP, which can produce severe elevation of a blood pressure. So we targeted MAP of 90 or more for those patients. Now we move to vascular emergencies. Acute aortic dissection, which is type B, the medical one. So our target is a rapid decrease of the blood pressure of less than 100 to 120 within 15 to 30 minutes. So we need that rapid response to decrease the blood pressure. So expanding hematoma may cause MI, stroke, spinal cord, or bowel infarction and acute renal failure. So we have two goals in the treatment of aortic dissection. The first one is about the heart rate. The second one is about the blood pressure. We don't do the second one before the first one. So the first goal is a target heart rate from 60 to 80 with beta blocker. Why is that? To prevent reflex cardiac stimulation. The second goal is to lower the blood pressure, the lowest tolerable level. So until the pain is relieved, completely relieved. Why? To arrest the ongoing aortic dissection. So nitro can be titrated till the systolic blood pressure from 100 to 120. Cardiac emergencies. The first one is acute heart failure. Our goal is to decrease the afterload, to improve the diastolic relaxation, and to decrease the pulmonary pressure. So improvement, it can be appreciated if the blood pressure decreased by 1 to 15% only. Of course, with the diuretics and anti-failure medication. In acute coronary syndrome, we have goal to reduce myocardial oxygen consumption, and it can be treated with nitroglycerin, clevidipine, nicardipine, or beta blocker. Perioperative hypertension, I took the most important information, so we will be focused on just small sentences like nitroglycerin should be given to a post-coronary bypass patient. If the patient is will go to surgery, but not cardiac surgery, blood pressure should be 180 and below. If the patient have chronic hypertension, the oral medication should be given at the morning of surgery. And adequate control will reduce the risk of bleeding from the suture lines, premature graft closure, and ischemic damage to organs at risk. Regarding renal emergencies, acute hypertensive nephrosclerosis, which is manifested by acute kidney injury with increased creatinine and microscopic hematuria, lead to glomerular ischemic and activation to renal angiotensin system, lead to exacerbation of the hypertension. So the dialysis may help in this situation. Renal crisis of scleroderma, it's an aggressive form of malignant hypertension in which proliferative endarteritis preceded hypertension. Progression of end-stage renal disease occur within 1 to 2 months. Aggressive pressure control with ACE inhibitors is indicated. So this is the only situation that we can use ACE inhibitor even if the patient in renal injury. Sympathetic overactivity resulting in hypertensive emergencies. We have withdrawal of medication like clonidine, propranolol, or other beta blocker, which will cause rebound hypertension. It may mimic signs and symptoms of pheochromocytoma. Also, we have sympathomimetic agents like amphetamine and cocaine. We aim to reduce the sympathetic drive by benzodiazepine, nitroglycerin, or hydralazine. There is something called autonomic dysreflexia, which is a spinal cord injury above T6, lead to loss of coordination of autonomic response on the heart rate and the vascular tone. So the patient will manifest by bradycardia plus high or normal blood pressure with evidence of above T6 spinal cord injury. Typical stimuli like distended bladder, constipation, or pain. In burn, there is 1/4 patients with second and third degree burn will develop hypertension in the first few days related to high catecholamine and renin. The drug of choice is nitroprusside. The last one is hypertensive emergencies during pregnancy. So usually they present with systolic of more than 160 and diastolic more than 110. We agree on the target that systolic 140 to 155 and diastolic 90 to 105. And first line medication for those patients is labetalol. Although hydralazine can be used, but it's associated with severe hypotension and maternal and fetal complication. There is a new recommendation to add oral nifedipine. Will lead to fewer doses required by IV and less time needed to achieve the control. Nitroprusside and ACE should be avoided in pregnant ladies. But I made for you one table regarding each disease and what we should use and what we should not use. I think this will be so helpful for us, especially in the on-call, because we saw those patients in on-call time usually. So in MI patient, we can use nitro, and beta blocker and nicardipine can be used together. In pulmonary edema and heart failure, beta blocker, nicardipine, and hydralazine should be avoided. In aortic dissection, as I mentioned before, the two goals of treatment, so we should start with beta blocker first, then nitroprusside or nifedipine. In malignant hypertension, encephalopathy, stroke, ICH, and sub-arachnoid hemorrhage, they all agreed on nicardipine because they believe that nicardipine is a neuroprotective agent that will not cause increase in ICP. So it can be safely used in cerebrovascular accident. Here in sub-arachnoid hemorrhage, we can use here per oral. Why is that? Because we can use nimodipine per oral because they suggest that it will decrease the vasospasm. And in pre-eclampsia and eclampsia, nitro should be avoided because it crosses the placenta. And as I mentioned before, nifedipine can be given orally to decrease the time of treatment. So it is important to consider other causes that may contribute to an increase in blood pressure, including full bladder, nausea, pain, pre-existing hypertension, hypoxia, or increased ICP. Old patients with carotid stenosis susceptible to CNS hypoperfusion from the beginning. So significant reduction in the setting of ischemic stroke may not be beneficial for them. So usually after 1 day of targeted blood pressure in the ICU, oral medication can be started and IV therapy titrated till discontinued. So take a home message. Most common cause is undiagnosed, untreated, inadequately treated hypertension. Treat aggressively in pulmonary edema and aortic dissection. Treat slowly in cerebrovascular accident and watch for improvement. Treat continuous IV infusion. Avoid boluses, avoid oral in acute phase. So even there is no single ideal agent, consider fast-acting, easily titratable, rapidly reversible, and safe medication. So this is my references, and thank you.
What we can get from this lecture that increase in the blood pressure, to call it hypertensive emergency, it has to be accompanied by end-organ damage. And we can think about whatever the organ, and then we can suspect what is the manifestation that will happen. So we can tell that the patient has an hypertensive emergency. Dr. Jawaher said that epistaxis and headache cannot be considered as an end-organ damage. So this is not related to hypertensive emergency. The rule is to decrease the hypertensive emergency, whatever the hypertensive emergency is to decrease the blood pressure slowly. So we'll go within first hour about 15%, and the next 23 hours another 15%. There is only one situation we have to go very fast, lowering the blood pressure, regardless of the initial blood pressure, which is the dissecting aortic aneurysm. We have to reach a systolic blood pressure less than 120 within 20 to 30 minutes, regardless of the initial blood pressure the patient presented with. The target of lowering the blood pressure is different from disease to disease. So in ischemic stroke, we can leave the blood pressure even if there is no thrombolytic therapy high as to 220 over 120 to preserve the penumbra area. But if the patient wants to receive a thrombolytic therapy, we has to go with the systolic blood pressure with less than 180 as fast as we can, so we can give the thrombolytic therapy. In intracerebral hemorrhage, we lower the systolic blood pressure to below 160 or sometimes to 140. But in sub-arachnoid hemorrhage, we can allow a higher blood pressure to 160 to 180. The important issue that we must have to read about is the medication we used in the hypertensive emergency. Usually the medication is intravascular medication, so we are not dependent on oral medication at all. Hypertensive encephalopathy is the disease of exclusion. So if I have the patient with confusion or mental changes, sometimes it comes with blindness even, and there is no ischemia or hemorrhage in the CT brain and the blood pressure is very high, so we consider it the hypertensive encephalopathy, and we're lowering the blood pressure as the usual hypertensive emergency issue. The most titrable and very effective medication to lower the blood pressure is the nitroprusside. Nitroprusside acts within 1 minute, and it lasts for like 10 minutes, its action. The problem in nitroprusside is two issues. First, the nitroprusside is very expensive drug, and it is light sensitive, so it has to be covered from light while we infuse it for the patient. The second important issue is the metabolism of the nitroprusside would end by cyanide. So nitroprusside can lead to cyanide poisoning. Nitroglycerin, and it is the nitroprusside, it is direct arterial vasodilator. نيتروجليسرين اعتبره انا الاخ الاصغر للنيتروبروسايد، وللامانه احنا معتمدين على النيتروجليسرين اكتر لان النيتروبروسايد احنا مش متعودين نستخدمه. النيتروجليسرين again it is هم النيتروبروسايد والنيتروجليسرين الاثنين بيزودوا حاجه اسمها السايكليك جي ام بي، ومن هنا بيعملوا vasodilation. لكن النيتروبروسايدز act on the arteries while the nitroglycerin mainly act on the venous system. This is why the nitroglycerin, when it acting in the venous system, it decreases the preload of the heart. So it has a very good use in hypertensive emergency related to heart failure or MI. While nitroprusside decreases the coronary perfusion and the cerebral perfusion. So it's better to avoid it in acute ischemic issue, in the acute brain problem or acute cardiac problem. Nitroglycerin is the better in acute MI and in the hypertensive pulmonary edema. We can achieve arteriodilator by nitroglycerin, but we need a very high dose. What is the problem in nitroglycerin? The problem that it increases the level of methemoglobin. So we have to look for the methemoglobin in the ABG frequently. The beta blocker is the drug of choice in most of the diseases except in the heart failure patient, because we said before in the heart failure lecture, if the patient has a weak lung, there is contraindication to use a beta blocker. Which beta blocker I have to use? There is two beta blocker I have IV form from it. One is alpha and beta blocker, which is the labetalol, and this is the most common drug we are using it. And you have to know how to use the labetalol because it is the frequently drug used in the emergency situation. So you have to know that you can give 10 milligram and you can repeat it until reach 40 or 50 milligram with controlling blood pressure and to continue an IV infusion. Usually انا myself يعني ما بحفظش قوي جرعات الادويه بصراحه لانها موجوده في كل مكان، لكن لازم اعرف مشاكله وعيوبه واخاف من ايه. بعدين ممكن ارجع لموقع زي الاب تو ديت او الليكسي واعرف بالظبط الجرعه ممكن تبقى كام عشان ما تملاش دماغك بارقام وتنسى الاهم. The other beta blocker that can be used is the esmolol. Esmolol is a selective beta blocker, sorry. So this is the two beta blocker that can be used. In the dissecting aortic aneurysm, beta blocker is the first choice. Why is that? Because it decreases the heart rate and decreases the blood pressure, so it decreases the shearing force in the wall of the aortic dissection. We don't have esmolol usually in the hospital. Usually we go for labetalol, but if there is calcium channel blocker, it's better also to be used. The calcium channel blocker nifedipine is the oldest one, and it's always used. Nimodipine is an oral one, no IV form of it. Nimodipine used usually in sub-arachnoid hemorrhage, and all we are used to use the nimodipine. But newly there is a new calcium channel blocker called clefidipine. Clefidipine is very ultra short acting calcium channel blocker. It's act within 1 to 2 minutes and lasts from 5 to 7 minutes. So clefidipine also, it's a very beautiful calcium channel blocker that can be used in all types of hypertensive emergency. Again, calcium channel blocker, we are not using it again in the patients with heart failure because it may have some myocardial depression. Hydralazine is direct vasodilator, but the problem in hydralazine is it has an unpredictable response. So it can lower the blood pressure very rapidly without reason. يعني نفس الجرعه نديها العيان تنزل الضغط جدا ونديها العيان تاني ما تاثرش قوي. فعشان كده ما بنحبش نبدا بيه ابدا as a first line of medication. لكن لان هو هيدرالازين is direct vasodilator we can use it in catecholamine excess اللي هي بتحصل مع العيانين اللي عندهم sympathetic overactivity. سواء نتيجه ان هم خدوا سمباتهم مايميتيك ميديكيشن زي الكوكايين الامفيتامين او ريباوند لما وقفوا الدراج كان بيشتغل من خلال ان هو بيبلوك السمباتيك اكتيفيتي. اهم دراج بيعمل ريباوند هايبرتنسيف امرجنسي اسكلونيدين، فلازم كلنا نحفظ الاسم ده. في دراج في الاخر كده زي ما انتم شايفين اسمه فندولا، اخر واحد في التيبل اسمه فينولدوبان، برضو احنا ما عندناش منه، لكن الدراج ده له ميزه كبيره جدا ان الدراج ده بيحسن الكدني بريفيوجن. يعني هو من ضمن الحاجات اللي هو بيعملها صحيح هو بيلورنج ذا بلاد بريشر بات ات دايليت ذا رينال بلاد فلو، بيزود الجلوميرال فلتريشن ريت، وهو عباره عن دوبامين 1 اجونست. برضه مش موجود عندنا وانا ما استخدمتوش، لكن مهم تعرفوا ميزته ايه. في دراج هي جواهر مش كاتباه في الجدول، لكن مهم جدا برضه نبقى عارفينه، وهو مش مستحب استخدامه لسبب بسيط، انه كمان بيعمل ليبايل كنترول بلاد بريشر زي الهيدرالازين كده، اسمه فنتولامين. فنتولامين از الفا بلوكر، ف نون سيلكتيف الفا بلوكر. احيانا بحتاجه لو انا هدي بيتا بلوكر، لانه في بعض الديزيز وهو مرض مهم جدا اسمه فايبروموسايتوما بيبقى عنده ادرينرجيك كرايسيس، فلازم اي هاف تو بليك بوث الفا اند بيتا. فعشان كده بنستخدم الالفا بلوكر and بيتا بلوكر او نون سيلكتيف بيتا بلوكر which acting on the alpha and beta together. المهم في المحاضره دي لازم نعرفه ان الهايبرتنسيف امرجنسي مفيش رقم، هي كل مريض وله سيتويشن، وكل مريض وله الليفل اوف ذا هايبرتنشن او الليفل اوف ذا بريشر I have to reach and when. فزي ما اتفقنا انه اللي عنده انترسيربرال هيموريج غير اللي عنده سب اركنويد، واللي عنده انترسيربرال هيموريج او سب اركنويد غير اللي عنده اسكيميك ستروك، واللي عنده هايبرتنسيف انكفالوباثي مختلف تماما عن اللي عنده ستيكنج اورتيك انيوريزم. اللي عنده اكيوت ام اي او اللي عنده هايبرتنسيف بالمونري ايديما كمان مختلف. الهايبرتنسيف بالمونري ايديما باي ذا واي مش محتاجين ننزل في المريض اكتر من 10 ل 15% من السيستوليك بلاد بريشر مع اللوب دايريتكس اللي بنديها and it will help the patient to improve so much and sometimes we may need to use non-invasive positive pressure ventilation. مش محتاجين نورماليز البلاد بريشر، محتاجين ننزل بس ل 15%، وده غالبا اللي بنعمله. في الحاله دي زي ما اتفقنا نستخدم نيتروجليسرين احسن ما نستخدم اي حاجه ثانيه، لكن ممنوع تماما نستخدم بيتا بلوكر في عيانين الهارت فيلير. كلامسيا والبري كلامس لانهم لهم سبيسيفيك كده سيتويشن. نيتروجليسيدز كونتر انديكيتد تماما في البريجننت ليدي. نيتروجليسين كان بيوزد، بيتا اند كالسيوم شانل بلوكر كان بيوزد. زي ما جواهر قالت ان فيديبين اورال دلوقتي واحد من الريكومنديشن تو ستارت ايرلي في الهايبرتنشن دورينج البريجننسي عشان نقلل الجرعه بتاعه الاي في اللي احنا بنديها. ده اللي انا بس كنت عايز اضيفه، واللي عنده سؤال يتفضل.